Go for it. You can go full screen, Dr. Ashraf.
Okay.
Lovely.
Good evening, everyone. Today I will present a progression of the one cases presented last week. This was the RDS. Today it will be pulmonary hemorrhage, complication of the RDS. Again, this is the extreme preterm female neonate 23 week, delivered in April 7 with emergency CS due to peripheral CS and severe preeclampsia. It was 535 grams. It intubated in OR and taken one dose of Servanta, transferred to the NICU. It put in the connected to pressure controller AC mode with volume guarantee. If it was this type, it was 35%. The first POCUS done, lung done after 10 hours to assess how it is needed for another dose of Servanta or not. We'll do another scan in 11, second scan, because the sudden deterioration, it was found is athlexis and treated by recruitment. This is presented last week. What happened this week in April 14, it is sudden deterioration as the protocol of crash BP protocol. The blood gases, the oxygen tension was 38, the saturation was 75, البي اتش 7 13، البي اس 2 كان was 63. الهيموجلوبين drop from 13 جرام to 10 grams. The first, the 6-1, because I 14, 15, 16, 17, I do follow up serial, but I make the scan last today. I present this is the 6 scan to assess the lung. This is an X-ray, first one, and this ultrasound with the second, the first one, RDS. When the follow-up sudden deterioration, say the whole lung, white lung, this is the with falafel cotton consolidation, white lung, في even pulmonary hemorrhage ICU. This also this is the one with the Texas. This is last one today. It is more aeration. It is good and no more pulmonary bleeding with this ultrasound today.
Beautiful
Remind
images.
us, this is the last week. This is the 23 week, 23 position, 535 gram. We found here subpleural consolidations. And found this is the bat wing signs. Here with ribs. Double Lura, irregular وفي subpleural consolidation وفي white lung with no A line. This is right lung, this is left lung. This is also the lateral with extended consolidation. This takes score 4, 2 by 2, and this is takes 3.
Yep.
The left lung is the same pathology. White lung, abnormal pleural line. And this is take before, and this took 2, 6, equals 13. I give Servanta, second dose of Servanta on this. This is going well in AC mode. 4 days later, it is sudden desaturation. I make an ultrasound in posterior segment with atelectasis. And this is all areas atelectic area.
Yep.
Here. After make increase the beam from 6, increase little bit to 7 to 8. After 8, to reach to 8 beep, I guess this view. The recruitment
Recruited.
is, yeah.
What
It's
was the
okay. It
interval,
is.
Dr. Ashraf, between scans? Just out of curiosity.
يعني when I make this, I make beep 6, beep 7. After 12 minutes, I make it again. It will still, after making 30 to 1 hour, 40 to 1 hour, it's like
Yeah,
this
sure.
after 8. I do a follow-up serial this is
Yeah.
the one at 11. At 14, the third one, the sudden deterioration, I found like this, like this.
Yep.
And if you found like this, Dr. Alok, some this is a band, this band, you can find there some small dots coming.
Yep.
Hypercoagulous dots. This is not a bronchogram. I think this is bleeding, active bleeding. This is right lung.
Sure.
This left lung is the same.
Yep.
The same. This time I changed from the EC to convention to high frequency oscillator. I started by map 14, increase little bit, then reached 18. After 18, I reached to the complete lung recruitment. After that, for the following day, 15, 16, 17, decreased the map one by one. I started by F280, now F235. Started by map 20, my map 14, we reached to 18, now 15. I make it volume guarantee. I have frequency volume guarantee. I make it volume guarantee 1 equal to 2 meter per kg.
Sure. It's a very good example of good recruitment of the lung over a period of time.
Yeah, this is one I see. This last scan today. Oh, sorry, I will share
No
again.
problems.
Sorry.
Yeah, no problems.
Sorry. I go to last slide. This one today. The pleural nice now. There is no more bleeding. It's just that's subpleural consolidation. This is the right anterior.
Yep.
Why not? Okay. This is lateral.
Yep. Small, very small effusion there as well. Yep. Yep.
Now the pleural line it is it is there is no more consolidation, no more
Yep.
active bleeding. This is a posterior segment what is hearable before. I think it is okay now. This is also this one. And the hemoglobin after blood transfusion, it was 16 now. Today is 16. Maybe I try to winning from the high frequency because the X-ray reps 9 to 10 reps today.
Yep.
I decrease the map again to I'll try to reach to 12. But after that, I will connect to convention again.
Lovely.
That's it for today.
Beautiful images. Beautiful images and very
Thank
nice
you.
cases. Thank you so
Thank
much.
you. Thank you.
Naveen, would you like to go next?
Oh, I can, Alok. Means I've got no problems, but after an expert, I think you'll have to pardon my complete ignorance. This is my first presentation, so I'm
No
going to
problems at
try.
all. Absolutely no problems. It's
This will stop other screen here.
I'm 100% sure you'll be absolutely fine.
Oh, please. Now, I've scanned, means last week I scanned 6 babies. And in fact, actually, I just need to mention there was a preterm, one of the 30-weeker twins had pneumothorax, which cold-light negative. No, actually not 30-weeker twin. This was a term baby, meconium aspiration, PPHN, was actually deteriorated after a bit on high frequency, nitric, and all those things. But then I'm pretty sure I've saved some images, which I'll get it next week.
Sure.
But in acute situation, cold light negative, and I had my scanner next to me, and I managed to pick pneumothorax, needled. There was good response. It was very positive feeling that this course
Amazing.
has helped. So which is good. So So the other thing is I've done 4 babies.
Yeah.
One of them I can go through a couple of babies and I actually have my images are on a micro DICOM, so I've saved it on here. So because it's a DICOM reader, but it doesn't seem to record loops. It's got just fixed
No
images.
problems. Absolutely fine. Absolutely fine. Yeah.
It's starting. I'm hoping in weeks coming by I'll be slightly more improved than this.
No,
So my
absolutely. No problems at all.
My first patient is a term. She's a girl who's, when I scanned last week, she was 10 days old. She was antenatally diagnosed to have diurnal atresia with normal chromosomes, so she doesn't have T21. The diurnal atresia was repaired quite early on day 3, and she was 6 or 7 days post-op. Briefly intubated, ventilated, but post-op on day 3, she was extubated, and now she was in air with no respiratory support, but purely there for establishing feeds. At this point, she was nil by mouth, but now she is over the weekend. We've started feeding her. She was on TPN at this point, so this is the images for her. So in here, you can see.
So I've just got one slide visible, patient 1. You might have to stop share and.
Yeah, no, I'm just going to go through.
Sure.
Because there are a few images on the side, so I'll just go through all the images. Means
we can't see them.
Oh, you can't see them.
We can't see them. You might have to stop share for the presentation, because yeah.
Yeah, no, so I'll say stop share and then new shares. Oh, thanks for reminding
No problems. Absolutely fine. Lovely.
So this is the first slide. So this was a L15. So this is the hockey stick.
Yep, it is.
Then and it was okay because we didn't have the linear probe when I did this scan, and I tried marking. So it's R2. So I started with R2 and then R3, left L1, L2, L3. So the first picture is R1.
Yep.
So there is you can see battering sign.
Yep.
2 ribs and essentially rib spaces and you can actually see the A lines quite nicely.
Yes. Yep.
And there are a couple of would you call this comet tails?
Yes,
rather than
they're comet tails which are visible. It's a beautiful image. Got good depth, right up to 4 centimeters. Your gain settings are beautiful. I can see an A line right down to the bottom. It's fantastic. Nothing to add.
So it's thanks very much, Alok. And this is R2 just going downwards. It looks again. So I think these are 2 ribs and that's a battering sign, and you can clearly see the A lines with literally no B lines in there. It was very well aerated lungs. It's the same at R3 again. Of course the loops are missing, so this is
don't worry. I mean, the images are very nice. You've got the anatomy in its totality. For me, the fact that you're getting really good, I would say, uniform penetration up to 4 centimeters is really, really good. You don't have gain settings that are incredibly high, which kind of means your pleura looks nice and isodense. Your ribs are visible. You've got rib kind of shadows that are visible with A lines all the way down to the bottom. This is really good. Nothing to add. Very nice image.
Thanks. And actually you could see the pleural movement as well, but of course not in this image when we scanned. So it's the same, which goes down to L1, L2, and L3. It means my essentially marker is something I'm still learning. I think L1, L2, L3 are quite close to each other, so it was tricky. So this I think is thymus.
That's correct.
At L3, and yeah, so that was essentially the last picture for this baby.
Yep.
So in the gist of it, just as this was a normal lung scan,
Yeah.
which showed means I didn't do the posterior ones. I just did the anterior and the infraaxillary area, and they all showed A lines. There was good pleural movement. Pleura looked clean,
Yeah.
and there was no other evidence of abnormality seen in those areas which were scanned.
Yep. I would agree.
So that's so the second ones. The rest of them were all means not abnormal. So this is the second baby. Is I'll just stop sharing and to learn to prepare a presentation well as well, actually, in the future. So this is a 24-weeker who is now 10 weeks old. She was 670 grams, now actually 2.4 kilos. Suboptimal preparation antenatally. Had just one dose of steroids a couple of hours before birth. Had one dose of Maxelf. Intubated, ventilated for a bit for 6 weeks. Also because she developed NEC. Sorry, not she. He developed NEC. Ended up in theater. Now has a stoma. Eventually, we were able to extubate him around 6 weeks of age with a DART regime. Gave him some steroids, DART regime steroids, and then he was on to CPAP. Now high flow of 6 liters. So he's gradually weaning off quite nicely. Clinically very stable. No respiratory signs of distress. And establishing feeds means we were stuck. Means he's on 50 mils per kilo of feeds and 100 mils of TPN. So that's his clinical picture. And the the ultrasound scan is think about that one. So this is the second baby, but this scan seems to have rearranged itself. But this one I had a linear probe, so this is a slightly longer probe for a really small baby, so you can see multiple rib spaces. And I think this was so this baby was prone, so I've only done the
back.
posterior AS scan, simply because once you get consent from mom,
you don't want to handle the baby too much. Completely understandable. Completely understandable. So it's a beautiful image. What do you think?
So this image actually, you can see multiple rib spaces. I think 1, 2, 3, 4 rib spaces at least, and you can see the pleura, which is not clean. So this is, would you call this subpleural thickening, is it, or?
No. So what you've got is, you're absolutely right. The pleura is not clean. You've kind of got areas of pleura. I'll just get my marker, that are visible here, 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 and then you kind of have no pleura here. You've got a slightly darkish region there, and quite irregular kind of consolidation here with what are some bronchograms with a linear shadow here. So this is basically consolidation with atelectasis and a B profile.
B profile, yeah.
It's basically lung that potentially could be recruited in this baby, which kind of, if you're at the back and you've been nurse prone, you kind of are as well recruited as you can be. But sometimes if you've kind of moved from supine to prone and you do a scan immediately, you'll still have areas of atelectasis. But beautiful image. I mean, the back is always my biggest challenge in extremely preterm babies because of the convexity, the arching of the baby, the amount of soft tissue that you often get. And you've basically got around that really nicely. So my compliments.
I probably was lucky. That's means, and here this is the R6. Again, I think the similar presentation. It's all predominantly B lines, but pleura is a bit more cleaner here. And you can see that a bit more. And this is also R6, and here it's a different area within R6, and here the pleura is a bit more broken, and you can see the bronchograms. So would you class this as possible consolidation, subpleural consolidation?
Yeah, this is an image which it would have been nice to kind of be able to see them in a loop,
In a loop,
because you've got soft tissue at the top
yeah.
that's visible. Now, my only comment is I think that's a rib.
Yeah.
I think that is also a rib. This looks a little bit crowded. And then you've kind of got the pleura coming off it again, which is quite thick over here, quite irregular, with these areas that look like they're linear bronchograms. So this area of the lung is definitely with consolidations. And the question is whether you've got a little bit of atelectasis. And in inspiration, you might find that the pleural line is formed, but in expiration, it tends to collapse because of derecruitment of the lung. But
Okay.
absolutely, I mean, from what you're describing, it looks like a baby who's got a B profile, evolving lung disease, with probably
Yeah.
what is a little bit of atelectasis.
Yeah. And
Yeah,
if
very
you
visible over
this
here.
is
It's a beautiful image. Yeah,
more visible, yeah,
yeah.
actually. So this is
R3.
the R3. I don't. So it's axillary area, and L5. It looks quite similar to R6. There are areas of within R6 and L5, so where you see
So
subpleural colon consolidation.
can I say, can we open this up to the group? Because this is an image that not many of you will see for quite a while. So let's see who we have. We've got Anne and we have Praveen. So Praveen, this is L5. It's the back. What do we think? You've got Anne for help.
Yeah, I'm having a look and I'm trying to think. We can't have two pathologies at the same time, can we? Atelectasis and there is this zone in the middle, which looks a bit. The pleura is not continuous there. It looks a bit like I don't know. I don't want to say fractal or shared sign, but it just looks a bit irregular in the middle. Whereas
Okay.
on the
So let's start protocol. Can you see a batwing sign?
at some places I think I can, but not throughout.
Okay, so that's a rib. That's a rib. That's a rib. To make it a little bit easier for you, it's a little bit tricky because, again, just coming back to Naveen's scan, the challenge of doing L5 is going to be at the back. Maybe the baby's arching a little bit, and you've lost a little bit of the perpendicular nature of the scan, which makes interpretation difficult. But those are ribs. Yep. So it's difficult to kind of see a batwing sign clearly, but if you take it with the eye of faith, that's a rib, that's a rib shadow, that's a rib, that's a rib shadow, that's a rib, that's a rib shadow. So technically, this should be a batwing sign in between. Does that make sense?
Yeah.
Okay. Now, next, what would you describe after that, pleura?
So I think I can see. I can't comment on the sliding. The pleura appears to be okay. I wouldn't say it's massively thickened. I don't know. I can't point here, but just below the pleura, that white appearance, I don't know what that is.
Yeah.
Yeah, just below it.
Can you see pleura? Can you see a defined white line anywhere?
Yeah, the white line. I think I thought that is the pleura.
This bit here?
Yeah, look, I thought that where you have pointed out was pleura, but I can't see it elsewhere. I just wondered, were you kind of catching more of the ribs or just kind of not being perpendicular to the lung? So you're catching either more rib, or it happened to me once I was catching spine rather than lung.
Yep, definite possibility that just Naveen, were you quite close to the spine?
Possibly. Means I moved all the way from the medial to lateral, from even at L5, all angles actually. So I might be closer to the spine.
Sure.
I think it was. I would probably guess it was lung rather than spine.
Okay. My gut feeling is you're probably right. I think the challenge that we need to highlight over here is when you're in this situation where you're not quite perpendicular, uh, it can be a real challenge at the back. And often the pressure that you apply makes the baby arch. Now, that may interfere with you getting a good batwing sign. And if you're not getting a good batwing sign, the question really from your perspective is, uh, are you able to interpret the pleural line correctly? And this is where I would say that there's potential that this image is difficult to interpret because we're not quite perpendicular. So we really want to get as perpendicular as possible.
Yeah.
And for me, I find that a real challenge at the back, especially with babies who are prone, using the hockey stick because the footprint is quite small, but you've got a really nice linear probe over here. So I think you've got pleura at the lateral end. The question is the lack of pleura at this end because we're not perpendicular? So it's a really good kind of an image to kind of say, so what can we do to get this more perpendicular? My advice would be it's looking at the pressure that you're applying on the baby's back. And really, if you can see me, what I'd say is I like the probe, if it's a linear probe, just to rest on the back. And if the baby's arching, just give him a little bit of time to relax. The other thing is making sure that you have really, I would say, good contact. Because the question from our perspective is whether we're losing a little bit of contact at the lateral end of the screen. And it's a really good slide to kind of highlight how I find the back really difficult sometimes, especially in a prone baby. So well done. I mean, you've definitely got a B profile from what I can see at the bottom.
Yeah.
Identifying the batwing sign is the difficulty. And what I do is I would go back to trying to see if I can get the pleura as horizontal as possible below the batwing sign by keeping my probe as perpendicular as possible.
Yeah. It's thanks very much. Means I might be in the next slides. I means I
go for it.
You can see that area I was worrying, so I just put some I scaled it down, but I think I don't even know what it means. So this is again the same thing.
My gut feeling looking at the entire image is you've got a massive area of lobar atelectasis. And that's really why I would say that at the moment, for all of you who've not seen lobar atelectasis, this is a beautiful image, not for the baby, I must say. So basically, that is a thin pleural line. You've got no pleura over here, but this is an entire area of atelectasis. Were these bronchograms static?
It was static bronchograms, actually. Yeah.
And you can see these areas of linear kind of air bronchograms. So that for me looks like lung atelectasis. You've got consolidation here with a lot of static air bronchograms would be my impression unless you say otherwise. So was this baby nursed supine and then turned prone?
Yeah, I think so, actually, because they had just done the cares and they moved him a different position. So the difficulty is in a baby who was stable. Otherwise, when you see this, I don't know what to do with it. Clinically,
I mean,
just
clinically, what I'd say is that really the question from your perspective is you'll find that babies who are nursed supine, and that's why it's really important to move them. And it might just be that keeping this baby prone over a period of time will help this lung recruit, because if your gas exchange is okay and the baby doesn't have much work of breathing, then clinically my advice would be there's nothing that needs to be done. This is about positioning, good care, growth. On the other hand, if this is a baby that's working really, really hard, or the FiO2 is 40-50%, and really, you want to kind of optimize recruitment here, to reduce your FiO2 and the effect it's going to have on the eyes, as well as the lungs. So it's really about clinical correlation. And what you might find is that just if this baby is prone, you repeat this after, a few hours, you might find that that area is well recruited. And with babies who have evolving chronic lung disease, this happens all the time. So it's really about clinical correlation.
Correlation, yeah.
But just to say, your depth penetration is beautiful. Should we go back to the last image? Yeah.
Yes.
So again, you have blood vessels there. It would have been nice to see. Any concerns with regards to infection in this baby? Is he on antibiotics?
No, he wasn't actually. Not at this point. Means of course early on when he was when he had NAC, but now he was quite stable. He was in fact being weaned from CPAP to high flow. I'd weaned in the early part of the week.
Yep. Yep.
So there's definite progress clinically.
Yep.
Other than the feeding side of it, obviously that was going to take a while. But
Yeah.
respiratory point of view, he was progressing.
So this is L5, and that is also L5. So the question is whether this is an inspiration and that's an expiration.
Okay.
Because it looks a little bit worse, this one.
Yeah, this one looks worse.
So I just wonder whether that's an expiration. So again, very good depth penetration up to 4 centimeters, good gain. The question is whether we can just get that little bit more, I would say, your probe perpendicular in that region.
Yeah. Perfect. Cheers.
Hello.
Yeah.
Could I just ask if you have a X-prem like this one and they are older now, if you had BPD with cystic changes, would it appear on lung ultrasound and would it appear like a small sort of localized region of... No, it
So
wouldn't.
again, it's very similar to the question I get asked about PIE. You'd be surprised how PIE can give you this appearance here that you see that Naveen is showing us in this slide. You can get exactly this image and think that this is if this is a baby who's basically deteriorated, FiO2 has gone up from 50 to 80%, you might get exactly this profile and kind of think, well, it's just a B profile with compact B lines. The pleura looks a little bit irregular. So the question is, should I start diuretics? And you do a chest X-ray and you've got horrible PIE. And if it's one lung, the management would change completely. You'd nurse with that side down. So I'd say that the kind of cystic chronic lung disease, the changes that you get, they're not reflected with areas that look cystic on the ultrasound or look lucent on the ultrasound. What you can get in those babies is if you have air trapping, you'll get A profiles. Alternating with thickened pleura and B profiles, you can get very similar kind of an appearance like that. So a lot of it depends on the distribution of air. Again, the element of the air fluid ratio, the area of the lung that you're looking at, and whether you've got air that's within the alveoli right up to the lung margins. So if you've got air trapping in one particular area with alveolar kind of recruitment right up, you'd still get an A profile, but you might get pleura that looks pretty thick and irregular in that region. And again, so there's no typical pattern for that, I'd say.
Okay.
Yep.
Thank you.
Cheers.
Carry on, Naveen. Beautiful slides.
Look, I've got two more babies to discuss, but I know there are two others waiting. Sujit's waiting, and so I can let them.
Should we do them next time? Because we'll have
we can do that
more
next time.
sessions for peer review.
Yeah. So
but thank you for these images. Very nice.
Thank you. Thanks for listening.
I would just say that if you're using a preset at the moment, this is perfect. I wouldn't change anything.
Yeah, so this is so we had an advantage. A rep came and actually helped us set it up. So yeah, it was very useful.
Yep.
Thanks very much.
Shruti, excuse me. Excuse me. Sorry.
Is the screen visible?
It is visible, Shruti. God bless you. You can go to
Okay, so I have only one case. So this is a late preterm, 36 weeks, with the suspected Down's phenotype. Was initially stable on CPAP, initial respiratory distress. Also had some heart disease with ASD and VSD, and some signs of early failure. Was on diuretic. On day 5, was noted to have some worsening respiratory distress with increasing FiO2, which rose from a baseline of 30% to 60% with increased work of breathing. So the child was actually changed from CPAP to NIPPV, and we got an X-ray done. And so this was the X-ray was there at the time of the degeneration. So there was, right side collapse consolidation kind of picture with a bit of mediastinal shift. And we optimized the NIPPV, we increased the PEEP, to 7 from a baseline of 5, increased the PIP, and then we made the position change as well, and antibiotics were added. And subsequently, with the blood work, CRP was high, and the blood culture also showed Klebsiella pneumonia, and the baby got treated with 14 days of antibiotics. So this was the initial X-ray when the baby was quite sick, and after the recruitment, position change, and management on NIV. So this was the X-ray like 3 days later.
Yeah.
So the ultrasound which I've done is like the 3 days later, not in the initial, like when the baby was sick. So this was the R1, what I got at that time. So I think so I can see the
So
battling sound.
it's a yeah, absolutely beautiful. But we've discussed this, Shruti. Can I open this up to the audience because it's such a beautiful image? So let's see. Alberto, what do we think about R1?
Hi. So good afternoon. We have by a systematic evaluation, we have here a very good Between sign. So we have 2 ribs, we have pleural line, and we have a lot of heart.
Very good.
So we can see very much of the lung. So I would probably try to do more laterally, probably an R3, just to see the upper part of the right lung. Probably would be the best approach, because here we have a lot of heart, so I can't interpret the lung as I would like to. I think a little bit of thymus in
Yeah,
the
you're
upper part
absolutely
of the
right.
lung.
That's thymus. And you're right. The heart is pulled all the way across. Very difficult to see any lung. And few things. The reason I'm asking, what are your differentials? If you saw this on an image without an X-ray in a baby who had mild respiratory distress at birth, what would your differential diagnosis be?
If I have these, sorry, I didn't understand.
If you just saw this image,
okay,
your mental modeling, you see an image like this, you're in R1, you've had a good go at trying to do R1 as you're describing, and this is all you can see in R1. What are your differentials? What are you thinking?
I want to know if the baby has or not a large pneumothorax that might displace the heart to the right. So
Yep.
I need a comprehensive lung ultrasound as well.
Lovely. So left-sided pneumothorax. Anything else?
Or
Yes, the heart more right with the heart more right with hyperdynamic heartbeat يعني.
Okay, so sometimes on babies who or on inotropes, you get a lot of kind of transmission impulse, but this is massive. I mean, you can see a large amount of the heart on that right side. So any other differentials?
You have a heart disease that might increase the chambers, that might have a huge heart as well.
Very good. Door-to-door heart. So fantastic. This is really important in the context of what we're going to speak about today. Very, very important. Because if you have a door-to-door heart with a whiteout chest X-ray, I've seen a drain put in and I've seen a baby die because people were confused that that was a pleural effusion immediately after birth. And really postmortem showed that the drain had basically gone into what was a massive, massive door-to-door heart. So again, R1, any other differentials?
So I would like to see if there is any obstruction of the right main right bronchus that might collapse the lung,
and
that's
pull the
why,
heart.
Yeah, pull the right to the right as well.
Yeah, lovely. I'm going to open it up to the audience now. Any other? If the baby is completely asymptomatic, nothing wrong.
And dextrocardia.
Very good.
Yeah.
Amazing. Dextrocardia. So those are kind of 4 differentials that are very, very important if you see a significant amount of heart on the right side. Well done. You guys are absolutely amazing. Go for it, Shruti. Lovely case.
Oh, this is the other video. So this was R2, which I tried.
Yep.
So R2 again, basically like the bat wing sign, I can see the pleural sliding, and again like more of the heart.
Yep.
This is R3. Here we can see the bat's wing. I can see some comet tails and the pleura moving and more of like B profile.
Yeah.
And the last one is R4 here. So I think
it's a beautiful image. And I just let's see who. So this is the benefit of using a scanner where the artifact is not being attenuated. This is the beauty of it. You're seeing at the bottom, just for those of you who ever record your images, that waviness that you see at the bottom is not because of the scanner. It's because you're taking a video from the phone. But does anybody want to interpret R4? Surjit?
Yes, sir. I can see the batwing sign,
Hmm.
and the pleura appears to be continuous. And like during inspiration, I think it is continuous, and during expiration, there is some subpleural consolidation seen.
Yep.
This middle, and otherwise pleural sliding is present.
Yep.
And there's a B profile.
Yep.
And during expiration, I can see A profile also. On towards the left, not A profile, I mean A lines are seen.
Sure.
Towards the left, I think liver is seen.
Yep.
And
Anything else?
like pattern. This
Anything
I can
else?
see few subpleural consolidate. Is that stretch sign or what? Like
Okay, so it's a very nice image. So what you can see, Shruti, you want to describe it? Let me not steal your thunder. Go for it.
no, here we can see that there's a little bit of hepatization and probably like a collapse kind of thing with
Yep.
straight margins and some like linear, I don't know,
Very
are
good.
those linear bronchograms? Is that like there
That's a
in
linear
between?
air bronchogram that you see at the bottom. So just again, this is a large lobar consolidation with atelectasis. So just when you see the upper half of the image, it's basically a B profile when the baby expires, with an A profile when the baby inspires that you see now. But as you move to the bottom, this large area is hepatization with basically linear air bronchograms. Now I can understand Sur Surjit's concerns. That area there looks quite irregular. So just over here, there. So you see it transiently. And this is really important. This baby is very tachypneic, is my impression. Is that the case?
Yeah, like
Which
somewhere
is
between 6,
Yeah,
7.
so which is why you've got a lot of, I would say, you've got a lot of pathology that's visible in one slide. I do worry that there might be a fractal sign in this region, but this is classically a very large lobar atelectasis at the bottom. So you've got everything, a right-sided collapse consolidation with some elements of aerated lung, possibly the upper half of the lung being better aerated. And the reason you can see that in R3 and R4 is because you probably have a significant atelectasis, which is pulling the heart towards the right side. Your image quality is very good. It's penetration all the way to the bottom. But this area here is also a common area where you find what is called occult atelectasis. Often babies are completely asymptomatic when they're born, don't have the lung bases recruited. And you get this area where, as you might remember, if you remember Douglas Blank's article, you don't have aeration of the lower parts of the lung when the baby's born. And classically, what you find is they're asymptomatic, but because of a lack of aeration, you get this kind of, I would say, triangular appearance. But in this case, this baby is clearly very symptomatic.
Yeah.
So if this baby had this kind of an appearance, what would you be thinking of? Shruti, what are your differentials?
So this is like collapse consolidation secondary to infection because clearly like the way the baby presented and also like
Yep.
the other biological parameters, the
Yep.
microbiology parameters, everything.
But if I had just intubated this baby,
Yeah.
what do we think? If I said I've just tubed this baby,
Yeah.
It's too much on the right.
yeah, I would really think of a right endobronchial intubation because your heart is pulled, with a significant, I would say, loss of the lobes on the right side, pulling the heart. So just again, the important thing to highlight in this case is how your clinical history and clinical correlation is very important. Go for it, Shruti. This
I
is
think.
such a beautiful case. Yeah.
Okay, so next. Yeah, so this is like the left side.
Yep.
L1, like basically here it was more of B profile. I can see the bat wing and then the lung sliding and the coalesced B lines. But other than that, it looked okay on the left side.
Yep.
Yeah. So, and then the baby recovered with antibiotics and got discharged after 3
Well
weeks.
done. Well done. But let's just go back to the X-ray. Let's let everybody have a look at the X-ray. So it's just to kind of see that you saw nice aerated lung in R3, alternating with a significant collapse consolidation and mediastinal shift. So it just goes to show how good ultrasound can pick up very much the pathology that you see on chest X-ray, and sometimes tell you even more. So
Yeah.
well done, Shruti.
Yes.
Very good images.
Thank you. I'll stop sharing.
Thank you. Dr. Surjit,
Yes, Dr. Alok.
go for it. Such beautiful cases today by everybody. I'm so grateful.
Is it visible, Dr. Alok?
It's visible, ma'am. Half century
Yeah.
होगी आपकी लगता है? Okay.
Okay, sir. So this is a late preterm baby, 36-weeker. Weight was 1.9 kg. This is just day before yesterday. This baby came to me and he was very stable. It was just mild tachypneic. So I just kept the baby on oxygen and IV fluids. And in fact, we started with feeds also, tube feeds. And after 24 hours, baby became more tachypneic and we put the baby on CPAP. But after again 2 to 3 hours, baby had more respiratory distress. So I thought of intubating. I intubated and put on mechanical ventilator. And I did a lung ultrasound
जी.
at around 29 hours of life. And this was, I thought of RDS and I did a scoring. And this was in R1. So I could score it as 1. And these were 6 regions, R1, R2, and the axillary area.
Mm.
And R2 was again, I scored it as 1.
Mm.
And R3 again was almost 1. And so this is, I think, left side.
Mm.
So these are 6 regions which I scored, and almost it was having a similar picture. So like the scoring was around 7 for me.
Mm.
So I thought this baby had respiratory distress and I somehow gave surfactant. And but then I did just thought of doing a cranial ultrasound, and I was actually not very much convinced that the
This is
scoring is only
respiratory.
6 to 7, and I have given the surfactant, but I have to rule out any other cause, or maybe there's some PPHN or something bothering the baby. So I put in probe for the echo,
Yep.
and we found it as infracardiac TAPVC just
Well done.
yesterday. And I then confirmed, and then we referred the baby today. So I'm not sure if with this lung ultrasound I should have given surfactant.
Let's see
But I
what everybody else thinks. Mental modeling. It's a beautiful case, and I'm just curious to kind of get others' opinions as well. So, Satish,
Yes, hello. Can you hear
what?
me?
Yeah, I can hear you. What do we think? These are Surjit's images. Very nice images again.
Yeah, sorry, I missed the clinical presentation. Is it okay, Sujit, if I have just the clinical background?
This baby was 36 weeker, 1.9 kg, presented to me and it was almost stable, mild tachypnic, just started on oxygen, IV fluids and some tube feeds later. But at 24 hours of life, baby was more tachypnic. We put on CPAP and FI2 requirement started increasing to almost 70%. So I intubated the baby and did this lung scoring in 6 weeks. Yeah.
So this is our...
Yeah, this was... I'm sorry, I have not named the regions. So I usually start from R1.
That's fine. So the R1, you could see clearly nice batwing sign and a pleural line, pleural sliding is present with subpleural consolidation, I think, with comet tails, and A line is visible. This is R1.
Yep.
I think there are some areas of atelectasis as well. I think atelectasis with the small subpleural consolidation.
Yep.
This is R2. Yeah, R2 looks better aerated with the liver coming in there. And again, sorry, I should start with the batwing sign and pleural sliding. It looks a profile in the R2.
This is definitely left side.
Is this R3?
This is the left side, probably L2.
That's left side, I think. That's
Yeah.
left side, isn't it? So, yeah, probably. Because, yeah, that's L1. So a lot of hard shadows coming in there. Yeah, I've got the batwing sign. Pleural sliding is present. Again, it's A profile predominantly.
Okay, this is yeah, that image is very important. The next one.
It's L4.
What do we think?
Can we play this image, please?
Yeah.
AB profile.
Is this L4, Surjit?
Yeah, might be L4.
Okay, here, yes, I can convince myself with 3 rib shadows and acoustic shadows from the rib. So the batwing sign. Yeah.
Any thoughts about gain settings?
I think it's maybe perhaps, I think we are losing the depth here. I think it's only up to 3.1 centimeters. I think.
So what I'd say is, Surjit, the images are great. The only comment I have is you've got very high gain settings. And the frequency that you're using at the moment, I can't see it on the screen, but what frequency are we using? That's 3 centimeters. Yeah.
I'm in my machine. I'm not sure about the frequency, how to adjust. I was asking you even last time.
Yep. Maybe what we can do is when you're using your machine, and especially if you're planning to do it this weekend, I'm free. We can arrange a bottom call. We'll have a look at it. So because your gain settings are high, your pleura appears quite bright. You do have aerated lung with bright kind of A lines. Now, the real question that you have to ask is, are those areas of subpleural consolidation actually comet tails, or are they subpleural consolidations? And that is the only comment I have, that when you have very high gain settings, it can make it confusing. Having said that, the other thing that comes to mind is it's kind of got A lines alternating with B lines. So kind of there's an element of double lung point, And we've kind of got areas where I'm not convinced I can really see subpleural consolidations, with areas where you might have subpleural consolidations. So that kind of uniform appearance that I would expect with RDS, I don't have. Be mindful of the fact I now know the diagnosis. I think it would not be unreasonable with what you see on this scan for you to give this baby surfactant. That would
Yeah.
be my answer. And really, in hindsight, the beauty of it is your mental modeling has convinced you that this is not the only thing, that there's something else, because actually you can see an element of well aerated lungs. So you've done all the right things. And I think that is the beauty of clinical correlation that you've shown over here. You've gone back. Did you repeat a lung ultrasound after surfactant?
No, I haven't.
Okay.
Because I got the diagnosis and then I didn't think of
No, that's
repeating.
okay. What do you think might have happened?
This was a case of obstructive intracardiac TAPVC. So, I'm not
So
sure.
normally what you'd expect a few hours after giving surfactant is well aerated lung. But if you have obstructed infracardiac TAPVC, you'll drop the PVR, you'll flood the lungs, and the B profile will get a lot worse. The challenge between making that diagnosis is you won't have a response to surfactant, and normally aeration takes a few hours. We normally recommend that you wait 3 or 4 hours. So again, serial lung ultrasound in conjunction with your clinical correlation. If the baby's getting worse and hasn't responded, it would be a good giveaway. But again, it's a beautiful case. Well done, ma'am.
Was there a chest X-ray, Sujit? Just out of curiosity.
Yeah, but the chest X-ray was mildly hazy, but the expansion was good and not white out kind of lung. It was not white out.
All the
It
more.
was
And
almost
again, if you're confused, I mean, I'm going to talk to my department tomorrow, and using both can really help in that situation. But I think in terms of kind of your clinical judgment, it's absolutely spot on.
this was just
Yeah,
one.
let's have a
Just
look at your echo.
yeah, just one the diagnostic like
Yeah,
this
subcostal.
This when I couldn't see two pulmonary veins in the crab view. I could see
Yeah,
only two veins. And I'll show you if I have. And this was in a normal scale. There was turbulent flow in the hepatic vein.
yep.
And don't know if I have captured subcostal. I don't have it. I have
Don't
it
worry.
otherwise. But in the subcostal, we had a small VSD. The PDA was left to right otherwise. And there was a ASD, which was right to left. And there was TR gradient.
Yeah.
That was almost 45, 40 to
So
45.
pure right to left at the atrial level.
Yeah, pure
Yeah,
right to
so it
left.
should always raise the possibility of a PAPVC or a TAPVC,
Yeah.
because usually even with PPHN, while it might be, you should have a bidirectional shunt, maybe right to left. Amazing. Well done. Thank you so much. So I am, over the next half an hour, what I'm going to do is I'm just going to share my screen. Okay, first is that okay?
Yeah, fine.
Thank you. So we have an interesting few cases to kind of show you today. Okay, can you see my screen full scale?
Yes.
Okay, so I'm talking to you a little bit about pleural effusion. So what we're going to do is we're really going to talk a lot about the diagnosis and management of pleural effusions using ultrasound. We're also going to talk about a few of the points that might tell us whether this is an exudate or a transudate. The most important thing from our perspective is that an ultrasound in isolation does not tell you whether this is empyema, whether this is clear fluid, kind of a chylothorax. It will not give you that, but there are some pointers that might tell you whether this is an exudative kind of an effusion. But most importantly, from our perspective, you can use ultrasound in real time, especially with pleural effusions, for therapeutic kind of taps as well as to kind of get your drains in the right place. Now, we already know what a pleural effusion is. It kind of fluid separates the visceral and parietal pleura. And the benefit of kind of using an ultrasound is it'll detect ultrasounds as kind of pleural effusions as small as 5 to 10 mils. The sensitivity and the specificity of diagnosis, especially of very small effusions, is much, much higher, has been demonstrated in adult and in neonatal studies. But the most important thing from our perspective is, I would say, besides the issues of minimal handling, reduced radiation, if you have a high drops who's got bilateral pleural effusions, and you have to put an X-ray plate under this baby who also has pulmonary hypertension to kind of confirm your pleural effusions. That's a lot of handling. Imagine then having to put drains in, repeat those X-rays, and then have to repeat those X-rays again if you have to adjust the drains. It's not easy. I think you will need at least one X-ray to kind of confirm drain position, which you can't see with an ultrasound. So the need for X-rays is not completely eliminated, but really what an ultrasound will allow you to do with a pleural effusion is actually allow real-time therapeutic management, especially if you plan to tap it. Now, in terms of kind of use to detect pleural effusions in neonates and children, the grade of evidence as espoused by Spinnick, there's strong agreement that, it is a good tool that can be used to detect and treat pleural effusions. In particular, benefits are being able to see small effusions, differentiating possibly whether it's an exudate or transudative infusion. Now, we know with Balick's formula that we can quantify a pleural effusion. And my take home message from today's session is try not to get too fixated with trying to work out what volume the pleural effusion is. What is more important is really what is the clinical presentation of this baby? Well, has he got significant work of breathing? Is there reduced air entry on the side that there's a pleural effusion? In a term baby, you can get shift of the apex right-sided pleural effusion causing mediastinal shift to the opposite side. What is the FiO2? What is the kind of carbon dioxide on the gas? I think putting all of this together will give you a much better feel of whether this is a pleural effusion that's significant, that needs therapeutic management, versus a pleural effusion that might be small, that might need just conservative management with observation. And then you might feel the need in certain situations to want to tap it to basically know its underlying nature, as you might do if you try to make the diagnosis of a chylothorax. But for me, I would say the safety that a point of care ultrasound brings into management of a pleural effusion is it helps me identify viscera both on the right and the left side. And I can't emphasize this enough. Now, traditionally, if you look at management of pleural effusions, what we normally say is that you have a triangle of safety, fourth, fifth space on the right and left side. Kind of once you head into the sixth space on the right side, you start getting liver, especially towards the posterior axillary line. You'll get a lot of fluid in that region. And sometimes the problem is if you've got air fluid interface or if you've got fluid in the most dependent areas of the lung, and if it's thick and very viscous, and you end up putting your drain in the fourth space, say, for example, which is the triangle of safety, the ability of that drain to then kind of give you an efficacious removal of that pleural fluid, especially as the fluid drains and that kind of chylothorax becomes more thick with a lot of kind of content and debris, can actually be quite challenging, especially if you're using pigtails. So really, there is the benefit of being able to identify the best site in terms of the pocket, the most dependent site, but more importantly, identifying that if you're going into that site, which may be the seventh space in posterior axillary line, that you're not going to hit viscera. Now, if you wanted to kind of use landmarks, I think you'd be very brave to want to put a drain in the seventh space in posterior axillary line. I mean, we together, all of us have kind of been doing neonates for probably 1,000 years between us, uh, and I'd like to think that I've never seen a drain go into viscera. I have unfortunately seen a drain put in wrong side, which is not great. And again, this is a really important aspect of point of care ultrasound that I want to emphasize. And this is why today's session is really important. Just remember that if you have a pleural effusion, you can see it on chest x-ray, right or left. You can label it. And before you put that drain in, you can bring that x-ray up and you can say, I confirm that I can see a right-sided effusion and I'm going in on the right side. That's not so easily done when you do an ultrasound, and that an ultrasound will have numerous images, right and left. You can imagine you're going to do a comprehensive scan. That's at least 6 regions on the right, 6 on the left. That's 12 images. And then to kind of confirm using the ultrasound to bring it up and confirm that you're going to do the procedure can get quite confusing. But just showing you clinical governance, when we spoke about it last time, if somebody has decided to label that wrong side and somebody else is putting that drain in, or maybe putting that drain in maybe 12 hours later in the next shift, and you've labeled it incorrectly, you can get into a lot of trouble. So just be aware that really there are benefits to ultrasound, but it's really important that we do it and we label correctly. I think a big benefit of ultrasound is the identification of loculated effusions. And I've been in a situation where I've had a chest X-ray. I have gone in an area that I thought the effusion was supposed to be present, but actually I got nothing. And then really what I did was at that particular point, I asked my pediatric radiologist to come and do an ultrasound with me. And what we really identified was a septate pleural effusion. And we just realized that what we're really going into is an area that is completely separated with what doesn't have a lot of fluid in it. So I think there are benefits. The pitfalls, obviously, that you have with kind of trying to do procedural therapeutic thoracentesis, either of a pleural effusion or a pneumothorax, there's a training period to it. You need to get familiar with how to hold and do the images in the scan whilst you're actually doing the procedure. You need to be able to keep that field sterile. And a real issue for us at this particular point is that we don't have targeted training towards trying to do this. Unlike our colleagues in pediatric interventional radiology, we don't have high quality training and simulation models. We've developed 3 at the moment, which we are going to use in our next course to kind of give people the experience of how they might be able to do this. Uh, Now, common causes of pleural effusion that we look at, obviously in our setup, the commonest cause I would say is non-immune hydrops with chylothoraces. Mnemonic effusions with exudate are less common, I would say, if you go to the UK in the West. But if you come to our part of the world in the UAE or you go to India, absolutely no doubt, you will find babies who've got frank pus and empyema in their chest. And I can still remember a case of tuberculosis where my professor told me, Alok, actually complete whiteout of the lung, and he examined the baby clinically, did percussion, and kind of said that really you need to tap this chest, and we tapped it and we got frank pus. So it can be hugely beneficial, but we can also get small pleural effusions with RDS, TTN, and meconium aspiration. Again, whilst not pathognomonic in helping us diagnose any of these situations, they may be present and they may obviously interfere with our ability to kind of make diagnosis if we have them. What do we see? Well, really, when you look at a pleural effusion, you'll see an area of visceral and parietal pleura that are separated, and you've kind of got this area that looks dark and anechoic. And with that, you have this kind of silhouette of the lung, which is collapsed. When you do M mode, it comes up as a dark area. So naturally, that's soft tissue, that's rib. So this is soft tissue that you can see at the top. Those are the ribs that you can see. And below the ribs, you basically have parietal pleura. And in that region, you have this dark area. Now, because this lung pulsates in and out with inspiration, expiration, depending on how tachypneic the baby is, you get this wavy appearance to the visceral pleura, which is classically called your sinusoidal sign. But more importantly, if you're doing kind of a linear scale and it's perpendicular higher up, you get this kind of sign, which is called quad sign, which is a quadrilateral sign that shows demarcation with the rib margins, parietal, visceral pleura. And really, these are some of the pathognomonic kind of signs of a pleural effusion. But a good example that I'd like to give you of a pleural effusion is the sensitivity of ultrasound. So if you look at this X-ray over here, there's no evidence that I can see that actually tells me that there's a pleural effusion. I mean, it looks very ground glass depending on the history. This could be RDS, could be droopy strep, giving you a ground glass appearance. But actually, when you look at the ultrasound, you get this area of subpleural consolidations with quite significant static bronchograms, is what I'd like to think. I can't see the images, but I've got this small region over here, a very thin rim that you can see where the parietal and visceral pleura separate. It's a very, very small effusion, and that's the sensitivity of ultrasound for you. I've already discussed, you can see loculated effusions. And really, the question from my perspective is, if you want therapy for something like this on antibiotics, I think really in our setup, what we'd be doing is speaking to our surgeons, possibly our interventional radiologist. This is certainly not something that I'm going to go and start putting drains in if I have a baby who's significantly symptomatic because of the risk of actually creating and doing more damage. This needs a surgeon to kind of look at. It needs a CT scan to quantify. And really, from our perspective, it's multidisciplinary management. Now, just in terms of diagnostic signs, very quickly, just to revise, you've already seen them, but this is classically what is a quad sign. So you've got ribs, you got parietal pleura, you got visceral pleura, you've got the whole of the diaphragm visualized. So you've got an absent curtain sign. Now, the curtain sign is not something that we've spoken to you about, so I'm going to talk to you about it today. But you've got lung collapsed with these air bronchograms, very, very well visible visceral pleura. And this kind of flaps in the wind with inspiration, expiration. But this is classically what a sinusoidal sign looks like. So this is kind of the hallmark of a pleural effusion. And really, this is what it looks like in real time. So again, a quad sign. So you've got the bat wing with the ribs. So soft tissue, bat wing with the ribs. You've got intercostal space. You've got a little bit of rib shadowing that you can see over here. But really what you've got in this particular region is parietal visceral pleura separated by a large anechoic area and lung that's basically bobbing in and out with inspiration, expiration. You've also got these kind of areas of what look like static air bronchograms. So this is classically what you call is the quad sign, demarcated by these particular areas. This is the jellyfish sign, as you can clearly see. So a lung basically flapping about. Very well demarcated diaphragmatic margin. So normally what would happen is the lung would overlap this margin. And if it overlapped this margin, you would not be able to see the lateral end of the diaphragm. And we call that the curtain sign. But because you've got fluid in that space, yeah, you can see the diaphragmatic margin kind of very, very well. I mean, this is just the quad sign again that you can see with the kind of anatomy as it's demarcated. Just another example of what I'd say is jellyfish sign. With a significant effusion, you've got diaphragm that's well demarcated, a sinusoid sign on the air port, you've got lung that's collapsed. So now, what is the curtain sign? Now, just be aware that if you have normal lung, and this is well aerated normal lung, on a chest X-ray, you'd be able to see the diaphragmatic margin with what is basically the costophrenic angle. And really, this costophrenic angle is very clear. It's very well demarcated on chest X-ray. But in an ultrasound, what we know is that lung tends to expand in inspiration, and it basically covers this margin. So what happens is you can see the medial margin of the diaphragm quite easily. But in normal kind of, I would say, longitudinal scanning, as you can see, often what you'll find is that the lateral margin of the diaphragm is completely covered. And this is basically called curtain sign, and this is normal. But when you have a pleural effusion, what you'll find is that will separate the visceral and the parietal pleura, and that means that the whole of the diaphragm is easily visible. Uh, the benefits of an abnormal curtain sign, I mean, it's fairly obvious over here, but when you have very small effusions, they can be picked up as small sickle-shaped areas right at the bottom. And this is just another very small curtain sign that you can see over here that has been masked. It's an abnormal curtain sign because you can see the pleura right up to the lateral margin of the diaphragm. This is classically what the jellyfish sign is described as, and this is an example of a jellyfish, but it's just lung that's basically floating in free fluid. Again, you've got parietal pleura is not very well visualized over here, but this is collapsed lung, and you've got these static air bronchograms within that are kind of visible, that appear and disappear. This is just an example of extended convex scanning, which I find incredibly useful when I'm doing lung ultrasounds for pleural effusion, in that I want to see a very large area, and especially towards the base of the lung, when I want to quantify where I think I'm going to really want to put my drain, see the area of maximum pocket. What I do is on my GE, I'll put on extended convex scanning. The normal images would kind of like with a hockey stick or a linear probe might give you 3 intercostal spaces with 4 ribs, but actually with an extended scan, 1, 2, 3, 4, 5, 6, 7, uh, I can see 7 ribs. I can see virtually the whole of the lower half of the lung. And really, from my perspective, it's giving me a really good delineation that this is probably not the best area to put my drain in, considering how close the parietal and visceral pleura are. But actually, when I look at this area, quite lower down, uh, I'm not going to hit any lung. I'm going to get a lot of fluid. It's also the most dependent part of the lung. So really, from my perspective, it's a really good example of how you can use the extended convex mode to actually give you really good image quality when you want to quantify and see what your pleural effusion looks like. But classically, lung will be consolidated, atelectatic, looks like tissue. You've got atelectatic lung here, consolidated lung here. You've got these areas of air and you have fluid bronchograms. So the air bronchograms are bright, they are constant, they're not disappearing, but you've got these dark areas as well that you can see. And this is actually fluid bronchogram. And I would be really worried that this is a syndemonic effusion, depending on the history, especially if you can see air and fluid bronchograms together. Uh, Again, just how close the lung can you see the margins? They nearly kind of coincide. Now, if you decide to do a diagnostic tap in this particular situation, there's a very good chance you might end up puncturing this lung, and you might actually cause problems with what is a hydropneumothorax. So you can potentially make things worse. The other sign that I'd say is very important is what is called the spine sign. Now, why does the spine sign happen? Now, what you can clearly see from your perspective is this is collapsed lung. This is the diaphragmatic margin. That's the parietal pleura. Now, this is really where your ultrasound waves are coming from. And what happens is fluid, as we know, is something that really acts as a good medium for the sound waves to be transmitted. So normally what would happen is you'd have pleura if the lung was well expanded in this region, and this lung and pleura, the pleura in particular, would be a reflector. So you'd have a pleural line, and that pleural line, if the lung was well aerated, would give you an A-line appearance. If there's interstitial fluid with alveolar fluid, you'd get a B-line appearance. But here the lung is completely collapsed and been replaced by fluid, which is a good medium for the sound waves to travel through. And then really what you've got is you've got the spine at the back. Now, the acoustic impedance between fluid and the spine is very high. So this becomes a very good reflector. And normally, if there was no fluid and just lung over there, most of the reflection would have happened at the level of the pleura, which kind of means the spine becomes invisible. It's masked because there's nothing for the sound waves to bounce off. They're not even going to reach. 90% of them will be reflected from the pleura. But here they can. They'll reflect, and you get visible vertebrae. And these vertebrae being visible is what is called a spine sign. And this is just an example. So this is L3. What I'm doing in this particular ultrasound at this particular point is I'm trying to quantify the area of maximum pleural fluid. And I'm basically using an extended, this is not convex, but really an extended scan to quantify the rib spaces to kind of see where my maximum pocket is. And in that, really, what I can see is ribs. I can see some element of rib shadow there. And then I've got this quad sign with basically an area that's anechoic. But over here, I can see vertebrae. This is the classical spine sign. And that's really a decent pocket of fluid, that I can tap quite safely. Now, in terms of kind of being able to talk about the nature of fluid, I would just be a little bit cautious of trying to say that this is pus versus a chylothorax versus kind of a mnemonic kind of exudative effusion, because we can't say that using ultrasound. What we can say is that we might find the effusion being echogenic because of what is inside it in terms of debris, fibrin strands, versus anechogenic fluid versus septations. And really, with the exudative kind of fluid, you tend to get, I would say, a lot of echogenicity. You can get fibrant strands with them. I think if you have pus, you get a lot of kind of dense material in there. Again, with hemorrhagic kind of effusions, we'll talk about a few of the signs, plankton sign and sedimentation sign, which you can see if you've got an acute hemorrhagic kind of effusion. But really, what I'd say is what you can clearly see in some exudative effusions is what is called the plankton sign. And the plankton sign basically means that you can see a lot of debris moving within the pleural effusion. You can also sometimes, if you've had a hemorrhagic effusion, see sedimentation of RBCs in a particular area. And really, that kind of is also called the hematocrit sign. But this is plankton sign for you. Again, that's your parietal pleura. You've got collapsed lung over here. You've got this area that you can see a lot of kind of debris floating in. The hematocrit sign is a little bit more dense and uniform in that the RBCs tend to settle in a particular area. Now, this is classically seen if you've tried to tap an effusion, you've punctured lung, there's been bleeding into the lung, and really you've decided, and you see and you do, and you repeat the ultrasound the next day, and you find you might have had, you tap, you get clear straw colored fluid if the baby's not being fed, in a baby who has high drops. You've punctured the lung, you may have had a small pneumothorax that's resolved, but you've had a hemothorax as well. This blood and it's sedimented down, and you get what is called the hematocrit sign. Uh, Basically, dense material, RBCs in that region, can settle down. Uh, Fibrinous pleural effusions tend to give you this kind of appearance of fibrant strands. So you can see basically the strand-like material that you see in the areas in between the ribs. So that, from our perspective, might be fibrin. A common kind of presentation of fibrin is if you've had a baby who's had a lot of chest drains, or where chyle has been drained, you've had drains that have come out, but you have residual effusion. So you can see these strands. You can have septate pleural effusions. So an ultrasound can give you a lot of information. So let's look at a case. So this is a case of a term baby having a post-operative repair of a TOF. The baby basically is 4 days post-op after having had an end-to-end anastomosis, kind of extubated after the fifth day of kind of being stable, and then kind of went on to some Optiflow. Day 6 to 9, the baby's been in air, and we've started feeds with some EBM, supplemented with some formula. So from day 9 to 17, this baby's gone on to full feeds. Now, day 23, we find the baby's got increased work of breathing and reduced air entry on the right side when you auscultate. So mentally, what's going through your brain when you kind of have that presentation? So let's ask Praveen. Praveen, what are you thinking?
I'm thinking of a pleural effusion.
Okay, great.
Post leak.
Very good.
Post leak. Yeah, that's one of the chances. But 4 days after surgery, so I don't know if a post-op chest X-ray was. Oh, you've got extubated now.
Yeah. So just to say that the baby basically had its repair, was intubated, ventilated for 4 days. So we normally keep them paralyzed if it's tight for 48 hours, then kind of wean. So kind of weaning ventilation after the end-to-end anastomosis kind of came down to settings where you extubated onto Optiflow day 6, 7, in air from day 9, no signs of respiratory distress. Feed started. So right-sided air entry on day 23 with significant work of breathing, going back onto Optiflow FiO 240.
So yeah, means one possibility still could be a late post-op tiny leak once you start feeding, but the other one I think is a chylous effusion, because you get that occasionally with tracheoesophageal fistula surgeries where the
anything else
lymphatic duct has been. Is there entry on the right side? So
anybody else? Any other differentials? And
it could be an aspiration.
Like just regular pneumonia, or a pneumothorax, I guess, as well. It could still happen. They're still, they've been on feeding support or breathing support. It's just happened out of the blue.
Yeah, aspiration as well. I'd say quite high on my list, considering a lot of these babies, especially as you go up on the volume of feeds, they tend to reflux. So you're absolutely right. I think really, really good points that both of you have mentioned. Kind of early clinical presentations like this of a leak post-operative repair is often air and could be fluid, saliva, potentially. So you could have a pneumothorax as well early on. Late on, it's a little bit unusual to have a leak so late, but it can happen. And again, you could end up with a pneumothorax with fluid in the chest, so a hydropneumothorax or just a pneumothorax. So all of those differentials in mind. So let's have a look at the lung ultrasound. I can switch the cursor off. So these are images, as you can see. They're still images. So this is the right side. What do we think? Praveen, just this image on the extreme right.
Just having a look, I think I can see a pleural effusion there.
Yeah. A small, large.
I would say reasonably, at least a moderate sized, I would say, at least a moderate sized or even large.
Yeah. So what I'd say is that, I mean, by Bailick's formula, this would be quite large, but if we just measure it, I mean, it's a good 8 to 10 centimeters. The lung is really collapsed. Now, it's quite surprising how we'd probably been examining this baby every day, but it's only when the baby becomes really symptomatic, when that lung really collapses, we've already accumulated a significant amount here. Now, what we've decided to do is a diagnostic paracentesis. And what you can see in this image is that's needle. And with the diagnostic paracentesis, what we also want to do is kind of give him a little bit of treatment. Let's see if we can decrease the work of breathing. So this is diagnostic paracentesis under, I would say, monitoring of the ultrasound. And really what I'm doing at this particular point is I'm monitoring that ultrasound, not by an extended convex scan that's longitudinal. I'm doing a transfer scan in the area where the pocket is maximum. And the benefits of being able to do that is, as I aspirate, I can see the volume of fluid coming down. Now, what is really important is you may not be able to see the needle in all planes because naturally, depending on how you keep your ultrasound probe, and really it's a little bit tricky because the ultrasound probe at this particular point moves about as the baby, kind of moves about, and that we're not going to tube and ventilate this baby. We've given him a little bit of sedation, a little bit of analgesia. And really what we're doing is a kind of an ultrasound in a moving baby, keeping it as sterile as possible while we're doing the tap. And you can see that actually the lung margin, the visceral pleura, is coming adjacent to the parietal pleura. And really what you can see is this margin here. I mean, you can just about see the needle there at that particular point. I can't see the needle here. But then after that, you get really close. And really what you want to make sure from your perspective is that you don't reach this situation because the needle is going to puncture the lung. And if that is the case, then really what can happen in situations like that is you can end up with a pneumothorax. But this is just an example of the chest x-ray. And when you look at the chest x-ray, this is really, it doesn't look so bad, but actually it is pretty bad. And sorry, my apologies. This is not this baby. This is a different baby. But what I'd say to you is that you just have to be extremely careful that you don't end up puncturing the lung. This is just an example again of another baby and ultrasound versus chest x-ray. And when you look at this effusion, it doesn't look significant. But when you look at the area of maximum pocket, I mean, there's a decent diffusion over there. And we'll talk about Bailick's formula and how you can monitor it. But really, this is a baby where we were in a significant amount of oxygen, and we ended up with kind of a significant pleural effusion, uh, which turned out to be a chylothorax post-PDA ligation, I think, if I'm not mistaken. Again, diagnostic paracentesis was done, and as I've kind of explained, that we've ended up puncturing the lung. Now, this was not done under lung ultrasound guidance. We didn't. And really, those are the risks. If you're doing it as a blind kind of a procedure, the risk is you'll puncture the lung. And while you've drained the entire effusion, you've ended up with a pneumothorax on the right side. Now, if you use ultrasound, you can actually monitor this. Now, how do you do that? Well, just always remember your baby is always going to be supine when you're doing this procedure. We don't do this procedure prone. The most important thing from my perspective is I like to put a drape under the baby, whether I'm putting a drain in that area, just to kind of elevate the region to make my landmarks very, very clear. Now, the normal procedure would be done in the fourth to fifth space triangle of safety, kind of mid to posterior axillary line. But really, with an ultrasound, what I can do is I can identify the maximum pocket. And the way I do that is, if you look at me, is by basically moving down in that region. So identify site, describe it, tell them that I'm actually looking at the right side. I would have done a comprehensive scan in both regions. A simple example, if you have a baby who has high drops and you want to put or do a therapeutic aspiration, diagnostic and therapeutic aspiration, well, it could be worse on the left. And if you end up tapping the right, so you need to do a comprehensive scan, ideally if the baby is stable enough to allow it. Identify which side is worse, and you really need to go for that side first. But you're moving down in each space in that region, and really what you're measuring is this distance. And when you see the area of maximum pocket, really that is the safest space. But really what you can also do then is also do what I call is a transfer scan in that region. And this is the transfer scan, which kind of tells you where the viscera is. So you're actually confirming in two places where you think it's safest for you to be able to put that needle or that drain in, and then be able to do it. It just lends a huge amount of safety. Where time permits, I'm going to be really honest with you, I would not be doing this procedure without having an ultrasound. I'm not saying that it's mandated. I think we need to realize there's an element of training that's needed. Again, this is just an example of really pleural effusions of different kinds. So, this is basically a transfer scan, multiple intercostal spaces. And this is a scan that's looking at one intercostal space in the effusion. So, jellyfish sign, as you can see, this is again extended convex scanning. You can see multiple spaces. This is before the tap and this is after the tap. So really you can quantify, you can see whether there's improvement. Again, just examples of pleural effusion before and after taps. This is just a diagnostic tap that was done on the left side in this baby. So our intention was not to drain everything. It was to do a diagnostic tap, and the baby wasn't very symptomatic. But again, the ability to do ultrasound really gives you a huge amount of protection in this particular situation. But more importantly, what I'd say from our perspective is that if you were to do a tap and your baby's kind of to develop significant respiratory distress, you can go back with the ultrasound in real time and you can diagnose a pneumothorax, as you can see over here. So really, this is a baby who developed a pneumothorax in real time. It's not one where we put a drain in. This is just an example of a baby who has a B profile and has developed pneumothorax, but this could well be a baby where you've done a tap and really you'll get the answer. In terms of volume of effusion, Bailik's formula is a common kind of a measured parameter that we use. It's the easiest one. There are no validated studies that actually look at the application of pleural effusion measurement in neonates. And the reason I've chosen this is it's quite easy to do. The idea is you measure the maximum distance in millimeters between the visceral and parietal pleura, multiply that by 20, and that gives you the pleural effusion volume. So really what you're doing is you're doing, as I said, transfer scans in each intercostal space, mid to posterior axillary line, and you're looking for the area of maximum pocket. You're looking for the collapsed lung, just largest pocket, measure the linear distance, multiply by 20, and that'll give you the volume. Now, my real kind of thought in that particular situation is clinical correlation is absolutely key. So before we finish, I'm really keen. So who have we got? Naveen and Satish. What do we think about the scan?
Is it Naveen or Praveen Alok?
Naveen and Satish.
Okay. Miss Satish, please join in. I can start with this.
Yeah, please do. Yeah, I can hear you. Yeah.
There's a large collection. But the only difficulty is I can't say where this is. And all I can see is there's an echoic mass. This is quite large. But I can't see batwing sign.
Very good. So you can't see a batwing sign. So because you can't see a batwing sign at this particular point, take my word for it that this is basically what I'd say is a transverse scan in an intercostal space.
Okay.
That is being done. So that's basically parietal pleura. That's visceral pleura. And that's a large anechoic area. What else can you see?
So, and there is debris, quite a bit of debris. So the question is that blood in there? And also the top end, is that a bit of lung, possibly lung tissue, which is possibly the case?
So just again, coming back to, there's a difference between debris, RBCs, and acute bleeding.
Yeah.
So if it was acute bleeding and this was fluid, what would fluid be? Anechoic or echoic?
Acute bleeding, it's echoic probably?
No, it'll be anechoic.
No?
Fluid is anechoic.
Okay.
It will allow sound waves to go through. You might, after a while have sedimentation, but really from your perspective, fluid would be anechoic. So if this was kind of acute bleeding, it would still be anechoic, maybe with slightly different densities of anechoicness. But here you've got brightness. So Satish, do you want to help Naveen?
Yeah, I mean, like you explained, Alok, it's a transverse scan with an echoic area with a large collection of fluid with echo-dense area, which are kind of floating from the base to the kind of, to the surface. So is it like a plankton sign we are looking here?
Okay, so let's just look at plankton sign. And you're right, I need to give you history. So this is plankton sign. How echoic does it look?
It's not that bright as we saw in the picture which we are analyzing now.
So what would be as bright? What would give you that kind of brightness? It's virtually bone bright. What is a really good reflector?
Air. Bone.
Very good. Air.
I think we have punctured the lung.
Very good. You've punctured the lung. So basically somebody has tried for most probably a diagnostic tap and has ended up puncturing the lungs. And what have you got over here is basically a hydropneumothorax. Now, the pleura is not identified because a lot of this air is basically going in, but is not reaching the pleura. So because it's not reaching the pleura, you can't see a bright pleural margin. Okay. Does that make sense?
Yeah.
So this is basically a bronchopleural fistula at this particular point, possibly, if it's continuous. Any questions?
No.
Any questions about the procedure?
Alok, one question, I think, about the extended convex imaging with the hockey stick. Is it feasible?
I meant to have a look today, Satish. I apologize. I wasn't able to because it was very busy.
No, I appreciate it. I just wondered whether whenever you get a chance, so please.
Yeah. So I just need to take the permission of a few of my colleagues before I can actually take images of our scanner. We're a little bit, I would say, strict about those things. But once we've got permission, I'll be able to tell you whether you can do it on the hockey stick. You can definitely do it on the linear probe with the GE without any problems.
Thank you, Alok.
Any other questions? I'm really grateful. I hope the session was good. Lots of nice cases and lots of food for thought. 2 more weeks, guys, and then it's, the course will kind of be over, but we'll continue with peer review for those of you who want to. That's not a problem. But just be aware, testing opens May 1st, will be open for 8 weeks. If you have really good reasons for wanting more time, I'm happy to give you more time. keep populating your logbooks. There's a good opportunity for people to kind of get the Dropbox is open to you. You can keep it for as long as you want. So even after the certification, if you continue adding scans to it and we meet the requisite numbers, we sign you off right up till L4. L5 basically means that you're already scanning.
Alok, can I just ask a really quick question? Sorry.
Please.
I had a bit of time today to go over some of the MCQs. Obviously, those are the practice ones. Do we get an opportunity to talk through some of those?
Yeah, absolutely. So if you want a one-on-one, we can do a one-on-one. It's up to you. I have a lot of time that I can commit to, so we can discuss them whenever you have time.
Okay, perfect.
Just like I said, the next 2 weeks is pretty open for me. I can work around your schedule, and that's open to everybody.
Okay, perfect. Thanks so much, Alok.
My pleasure. God bless you all. Thank you so much.
Thank you. Thank you.
Thanks very much.
Thanks, Alok.
Pleasure.